picture this scene, right? It's 4 in the morning in a hospital emergency department.
Never a good time.
Yeah, exactly. So a 61-year-old man is brought in by his wife. He was diagnosed with small cell lung cancer about 8 months ago, but right now he is sitting on the edge of the bed and he's just completely confused. He's running his high fever. His right hand is trembling uncontrollably. And within an hour, 4 different specialists walk into that room.
Right.
They look at this staggering, overwhelming list of abnormal lab results. And each of these highly trained doctors correctly identifies a massive, life-threatening emergency.
It's like watching that old parable, the one about the blindfolded men touching different parts of an elephant in real time.
Oh, right.
Like one feels the trunk and says, oh, it's a snake. Another feels the leg and declares it's a tree. I mean, they're all gathering incredibly accurate data about the specific part of the animal they're touching. But because they can't see the whole picture, their conclusions are just dangerously incomplete.
Yeah, they're trapped in their own little bubbles.
Exactly. We see this trap of local optimization everywhere, right? In business and engineering, and as we're going to explore today, in the ultimate high-stakes environment of an intensive care unit.
And that is actually our mission for today's Deep Dives. We are unpacking a genuinely mind-bending medical case study drawn from a set of ICU clinical notes. But our goal here isn't just to teach you a bunch of medical terminology.
Right, it's much bigger than that.
Exactly. We are using this case to explore how true experts can fall into the trap of tunnel vision when they're drowning in overwhelming data. And more importantly, how to spot the hidden connections in complex systems.
Yeah.
So whether you work in healthcare, manage a massive engineering project, or you're just a person trying to navigate a world built on information overload, this deep dive is for you. It's really a masterclass in why you can never, ever look at just one piece of a puzzle without asking how it changes, like every single other piece on the board.
Because the stakes here make for a perfect case study. I mean, the margin for error in this ICU room is effectively 0.
Yeah.
Every single intervention they attempt interacts with another vulnerability in the patient's system. It's just a cascading sequence of dominoes.
Okay, let's unpack this. Let's look at what those 4 specialists actually saw.
Yeah.
So first, the internal medicine intern walks in. He sees the fever, looks the white blood cell count, and it is critically low, just 2.4. Very
low.
Right. So he says, this is febrile neutropenia. The patient basically has no immune system. We need broad-spectrum antibiotics immediately. So that's fire number 1. Then the neurology fellow walks in, looks at a CT scan of the patient's head, and sees that the cancer has spread to the brain. There's severe swelling, cerebral edema, and it's physically pushing the brain off-center. He says, neurological emergency, give him steroids to bring down the swelling. Fire number 2.
And then the nephrology fellow steps up to the chart, and they're looking at just wild, chaotic electrolyte imbalances. The uric acid is through the roof, phosphorus is sky high, and calcium is dangerously low.
Right.
So they diagnosed tumor lysis syndrome, which is this catastrophic metabolic emergency where the cancer cells are literally breaking down and poisoning the blood. That's fire number 3.
Wow. And finally, the oncology fellow walks in. He sees the patient's right calf is swollen, oxygen levels are dropping, and a test called a D-dimer, which measures blood clotting, is sitting at a wildly high 8,400.
Yeah, that's massive.
So he says the patient has a pulmonary embolism, blood clots in his lungs. Fire number 4. 4 brilliant specialists, 4 distinct fires burning all at once. But in all that chaos, all 4 of them completely miss the 5th diagnosis hiding in plain sight. I mean, how does a team of top-tier doctors miss something so crucial?
What's fascinating here is that the clue isn't hidden in some, obscure, highly specialized test.
Yeah.
It's sitting right there in the basic coagulation panel. It's a single lab value called fibrinogen. And this patient's fibrinogen is 820 milligrams per deciliter, which is a massive elevation. But think about the psychology of the room, right? The specialists are so zeroed in on their specific domains, the missing white blood cells, the swelling brain, the chaotic electrolytes, the massive blood clots.
They're just totally focused on their own fires.
Right. So their brains simply filter out the elevated fibrinogen as background noise. They read the number, maybe assume, oh, it's just general inflammation, and they just move past it.
But that 820 isn't just noise. It's like the skeleton key to the entire puzzle, right?
Without a doubt. When you combine an elevated fibrinogen level with a wildly high D-dimer, very low platelets, which, by the way, we're sitting at a precarious 44,000 in this patient, and an active aggressive malignancy like small cell lung cancer, You are looking at the absolute hallmark of Trousseau syndrome.
Trousseau syndrome.
Yeah. That is a cancer-associated hypercoagulable state. In plain English, the cancer itself is causing the patient's blood to clot spontaneously all over their body.
So for you listening, what's crucial to understand here is why the direction of that fibrinogen number matters so much. There are a few different conditions that look really similar on paper because they all involve runaway blood clotting. But the fibrinogen acts as a compass pointing you to the true cause.
That's the dividing line. Like, let's look at a condition like DIC, or disseminated intravascular coagulation. In DIC, the body's clotting system goes completely haywire and just burns through all your available clotting factors trying to plug invisible holes.
Right.
Because those materials are being consumed so rapidly, your fibrinogen level is extremely low.
Okay, that makes sense.
Then you have another condition, TTP, which is primarily an issue with the platelets clumping together. It doesn't consume fibrinogen in that same systemic way. So in TTP, the fibrinogen level usually looks completely normal.
But in Trousseau syndrome, the fibrinogen is high. It's an acute phase reactant being aggressively driven by the cancer itself.
Yeah.
It's like, think of the body's clotting system like a manufacturing supply chain. In DIC, the warehouse has been completely looted. Everything is gone, all the supplies have been used up, so your inventory levels are super low.
Yeah, perfect.
But Trousseau syndrome is like a factory stuck in overdrive. The cancer factory is churning out raw clotting materials so aggressively that the production massively outpaces the body's ability to consume them. The materials just pile up, which is why the levels are sky high.
That analogy perfectly captures the mechanism. The factory is overproducing. And recognizing that we're dealing with Trousseau's overproduction and not DIC's depletion is vital. It completely alters how you have to manage the very next crisis on the board.
Which brings us face to face with the silent trap of tunnel vision. Because remember, the patient has blood clots in his lungs. The oncology fellow wants to treat that pulmonary embolism by restarting the patient's oral blood thinner. He was taking a common, direct oral anticoagulant, a DOAC, called rivaroxaban, before he came to the hospital. But he had run out. So the fellow's logic is straightforward. The man has a clot, give him his rivaroxaban. But if the nurse actually handed the patient that pill right now, it would be a fatal mistake.
This is exactly where compartmentalized thinking becomes so dangerous. The oncology fellow is only looking at the clot, but we have to zoom out and look at the whole patient. Remember the internal medicine intern?
Yeah, the guy who diagnosed the febrile neutropenia.
Exactly, the lack of an immune system. The absolute standard of care for a neutropenic cancer patient with a fever is to start strong azole antifungal medications. You have to do this to prevent or treat deadly fungal infections.
And when you put those two treatments in the same body, you trigger a lethal collision.
You really do. You see, drugs like rivaroxaban are cleared out of the body by specific processing systems in the liver and the gut, specifically the CYP3A4 pathway. Those azole antifungals are potent inhibitors of those exact same clearing systems. They essentially shut down the liver's ability to process and remove the blood thinner. If you give the patient the antifungal and then give them the oral blood thinner, the blood thinner just builds up and up. The plasma levels can spike 2 to 5 times higher than intended.
Wow. So effectively, you're giving a patient up to 5 times the normal dose of a highly powerful blood thinner. And let's remember the rest of the board here, right? This patient has brain metastases.
Yes.
He has tumors in his brain that are already swollen and bleeding microscopically, plus his platelets, the cells that help stop bleeding, are incredibly low at 44,000.
Right. So if you introduce a massive unintended overdose of a blood thinner into that specific environment, you are virtually guaranteeing a catastrophic intracranial hemorrhage. You will cause a massive unsurvivable brain bleed.
Wait, let me play devil's advocate for a second here. If we know the liver's clearing system is blocked and we know the drug levels are going to spike 2 to 5 times, couldn't we just, get clever with the math?
What do you mean?
Could we give a tiny microdose of the blood thinners, literally cut the pill into quarters to balance it out?
It's a tempting thought, I'll admit, but it's a gamble you can never take in a crashing ICU patient. The rates of drug absorption and clearance in a critically ill body become completely chaotic and unpredictable, especially since this patient's kidneys are also starting to fail.
Ah, right.
Major medical trials for these oral blood thinners like Caravaggio and Selecta-TD explicitly exclude patients with brain metastases and very low platelets for this exact reason. You just cannot control the drug once it's in their stomach.
So we're basically trapped. We can't let him die from the blood clot suffocating his lungs,
Right.
but we absolutely cannot blow out his brain with the oral blood thinner. So what is the path forward?
The only safe move here is to use unfractionated heparin given through an IV. Heparin is a completely different class of blood thinner that bypasses the liver and gut pathways entirely.
Oh, so it just skips that whole CYP3A4 interaction.
Yeah. Exactly. It has zero interaction with the azole antifungals. Furthermore, because it's an IV drip, it is adjustable minute by minute. If a bleed in the brain does occur, you can turn off the drip, push a reversal drug called protamine, and instantly neutralize the heparin in the bloodstream.
Wow. It's the ultimate precision tool when you have zero margin for error. And we desperately need that precision because while the team is figuring out how to safely thin his blood, the patient's actual cellular structure is failing.
Yes, his cells are quite literally exploding.
Which brings us to the third fire, tumor lysis syndrome, or TLS.
And the mechanics of TLS are just terrifying. The cancer cells are dying, bursting open, and spilling all their toxic internal contents directly into the bloodstream. What makes this specific case so alarming is that his last chemotherapy session was 3 full weeks ago.
Oh, wow.
Yeah, this isn't a reaction to recent chemo. This is spontaneous TLS.
Which means the tumor burden inside his body is just incredibly aggressive. It's growing so fast that it's outstripping its own blood supply and destroying itself.
Exactly.
And when those cells burst, they release massive amounts of uric acid. This patient's uric acid level is sitting at a massive 9.2. Uric acid at that concentration forms sharp crystals that completely shred the microscopic filters of the kidneys. So to save the kidneys, the team needs to use a highly specific drug called rasburicase, which chemically degrades the existing uric acid into a harmless water-soluble substance. But before the nurse hangs that IV bag, there's a massive red flag they have to check.
They absolutely must test the patient for a genetic condition called G6PD deficiency. See, rasburicase does a phenomenal job breaking down uric acid, but the chemical byproduct of that reaction is hydrogen peroxide.
Wow, okay.
Right. In a person with normal enzymes, their red blood cells can easily neutralize that hydrogen peroxide. But in someone with G6PD deficiency, they lack that defense mechanism. The hydrogen peroxide builds up rapidly and shreds their red blood cells, causing severe hemolytic anemia.
Imagine trying to save a patient's kidneys and accidentally destroying their entire blood supply instead.
Yeah, it happens.
But here's where it gets really interesting. Let's look at another number from the labs.
Yeah.
The patient's calcium level is 6.9, which is incredibly low. My first instinct, and I think the instinct of anyone looking at a flashing red, low calcium alert would be, his calcium is tanking, we need to pump him full of IV calcium immediately.
Do that, and you will destroy his kidneys permanently. You absolutely cannot replete the calcium.
It feels so counterintuitive. Like, explain the underlying logic there.
Again, you have to zoom out and look at the entire system. Why is the calcium so low in the first place? It's because those dying cancer cells are also releasing massive amounts of intracellular phosphorus into the blood. His phosphorus is critically high.
Okay.
Phosphorus and calcium have this magnetic attraction to each other. When you have huge amounts of phosphorus flooding the bloodstream, it aggressively binds to whatever free calcium is floating around. Together, they form calcium phosphate crystals.
So they form a kind of microscopic concrete in the blood.
That's a great way to visualize it. And that concrete deposits directly into the renal tubules, the delicate internal plumbing of the kidneys, causing immediate and severe acute kidney injury.
So the calcium isn't actually missing, it's just being hijacked by the phosphorus to make these destructive crystals.
Precisely. If you look at that low calcium number and decide to add more calcium to the blood, you are just throwing more fuel on the fire. You're handing the phosphorus more building materials to create more crystals, accelerating the destruction of the kidneys.
That's incredible.
The only way out is to lower the phosphorus, not raise the calcium. The only exception to this rule is if the low calcium is actively causing seizures or lethal heart arrhythmias. Otherwise, you leave it alone.
And to help clear all that toxic debris out of the body, you naturally want to flush the kidneys with IV fluids. But even the choice of the fluid bag matters here.
It does. You have to reach for normal saline. You cannot use the other common hospital fluid, lactated ringers.
Right, because lactated ringers contains potassium. And since the cancer cells are bursting open, they are already flooding the bloodstream with their internal potassium. Giving a patient even a little bit more potassium in their IV fluid right now would trigger a lethal heart arrhythmia.
Yeah.
It's just one hidden trapdoor after another.
And unfortunately, those trapdoors are opening faster now. because the kidneys are taking damage from the TLS crystals. They're shutting down. They aren't making urine anymore. So all this IV fluid the team is pumping in to flush the kidneys is just building up inside the body with nowhere to go.
Yeah.
And that makes managing the fluid levels in his brain an absolute nightmare.
Which brings us to hour 8 of this crisis, the tipping point. The patient's clinical picture rapidly deteriorates. His right pupil dilates to 5 millimeters and becomes totally fixed, like it doesn't respond when they shine a light into it.
This is a classic sign of uncal herniation. The cerebral edema, the swelling around those brain metastases we talked about earlier, has gotten so severe that the brain tissue literally has nowhere else to go inside the rigid skull. It begins pushing the medial temporal lobe, specifically a part called the uncus, physically downward.
And as it pushes down, it compresses the third cranial nerve, the oculomotor nerve, which controls the pupil. What's vital to remember about the physical anatomy here is that the brain swelling compresses the nerve on the same side as the herniation. It's ipsilateral.
Right.
So a blown right pupil means the right side of his brain is actively herniating downward.
The team needs to draw fluid out of the brain immediately before the brainstem is crushed. The standard treatment here is hyperosmolar therapy. They use heavily concentrated salt water, called hypertonic saline, to literally pull water out of the swollen brain tissue and into the blood vessels through the power of osmosis.
Okay.
They're intentionally driving the patient's blood sodium level very high, targeting around 145 to 155.
Now, I want to clarify a crucial distinction here, because we mentioned earlier the patient has small cell lung cancer. That specific cancer is notorious for causing a condition called SIADH, where the tumor secretes a hormone that makes the body retain water, severely lowering blood sodium.
Very common.
If we were just treating SIADH on a normal day, our target sodium would be totally normal, around 130 to 135. We wouldn't want it high, because raising sodium too fast in an SIADH patient causes osmotic demyelination syndrome, which is this horrifying condition that strips the protective coating off the nerves and can literally leave a person locked inside their own body.
That is a critical nuance. But in this moment, we are dealing with active brain herniation. The rules change entirely. You have to push the hypertonic saline fast and target that high sodium level to save the brainstem from being crushed. And notice that the team specifically chooses hypertonic saline over the other common brain swelling drug, mannitol.
Right, because mannitol acts as a heavy diuretic. It forces the kidneys to excrete water, which would further destroy his already failing kidneys.
Spot on. But while they're desperately trying to shrink his brain, the next round of blood work comes back, and the situation has completely inverted. The Trousseau syndrome has just vanished.
This blew my mind. The fibrinogen suddenly plummets from that sky-high 820 down to 680, and it just keeps falling. Smears of his blood start showing schistocytes, which are fragments of violently shredded red blood cells. How does a factory stuck in overdrive suddenly run completely empty?
The trigger was an infection. The blood cultures they drew when he first arrived came back positive. He had Staphylococcus aureus, specifically MRSA, growing aggressively from a central line catheter. The patient had developed severe sepsis.
So the bacterial infection hijacked the entire clotting system.
Yes, the bacteria triggered a massive systemic cytokine storm. This severe inflammation activated tissue factor expression on cells all over his body. It threw the patient out of the relatively compensated Trousseau state and pushed him into overt, raging, disseminated intravascular coagulation DIC. Now, the coagulation cascade is completely unhinged. It is consuming clotting factors faster than even the cancer factory can produce them, pushing his IST score up to a 7.
Which means we enter the final phase of this deep dive. We're no longer looking at isolated emergencies. We're looking at a system in total collapse. The patient is bleeding uncontrollably from DIC. The kidneys are shutting down from the tumor lysis crystals. The brain is swelling and herniating, and there is a raging MRSA infection in his blood. Every single treatment going forward has to be perfectly, meticulously calibrated.
Let's follow the dominoes, starting with the DIC. The fibrinogen is crashing, which puts him at severe risk of spontaneously bleeding into his already swelling brain. They need to replace the fibrinogen immediately, but they're trapped by physics.
Right.
The standard way to give clotting factors in a hospital is by transfusing fresh frozen plasma, or FFP.
But the math on FFP is a death sentence for this guy. FFP requires over a liter of fluid to deliver a meaningful amount of fibrinogen to the body. If you pump over a liter of extra fluid into a patient whose brain is already swelling and herniating out of his skull, you will literally pop the brain. You simply cannot do it.
So, to bypass that trap, you use cryoprecipitate. Cryo is a highly specific blood product that is essentially a concentrated paste of fibrinogen. It's 10 times more concentrated than FFP. It delivers the massive dose of clotting factors he desperately needs in a tiny fraction of the fluid volume. When every drop of fluid could worsen the brain herniation, cryo is the only option.
Okay, so fibrinogen is handled. Then there are the failing kidneys. They aren't making urine. The toxic crystals and potassium are building up, so they clearly need dialysis to clean the blood. But again, you can't just order standard dialysis, can you?
You can't. Standard intermittent hemodialysis, the kind most outpatients go to a clinic for, is incredibly aggressive. It acts like a fire hose, pulling 2 to 4 liters of fluid out of the blood in just a few hours.
Right. And if his brain is already swelling and his body is in shock, wouldn't yanking that much fluid out that fast just instantly crash his blood pressure?
It would tank his blood pressure, yes, but the hidden danger is much worse. Standard dialysis causes rapid shifts in osmolality. By pulling solutes out of the blood so fast, the blood suddenly becomes very dilute compared to the dense, swollen brain tissue.
Oh, I see where this is going.
Yeah, through the basic laws of reverse osmosis, water will actually rush out of the blood and into the brain, massively worsening the cerebral edema and the herniation.
So a standard dialysis machine would actually squeeze more water into the exact brain we were trying to dry out. It's wild how every instinct has to be second-guessed. So what's the alternative?
You use continuous renal replacement therapy, or CRRT. If standard dialysis is a fire hose, CRRT is a slow-drip coffee filter. It runs 24 hours a day, pulling fluid and toxins off at a very slow, continuous, gentle drip. Because it's so slow, it doesn't cause sudden drops in blood pressure, and crucially, it doesn't cause those dangerous reverse osmosis water shifts into the brain. It also continuously sweeps the dangerous potassium and uric acid from the dying tumor cells out of the body.
But wait, anytime you run blood outside the body through plastic tubes and filters, the blood naturally wants to clot. Normally, you'd pump the patient full of systemic heparin to keep the dialysis machine running smoothly. But we just said he's in overt DIC, burning through clotting factors and at risk of bleeding into his brain. How do you keep the machine from clotting without causing the patient to bleed to death?
This is one of my favorite pieces of critical care engineering. It's called citrate regional anticoagulation. You infuse a chemical called citrate into the plastic tubing before the blood hits the dialysis filter. Citrate acts like a chemical sponge. It strongly binds to all the calcium in that specific section of blood, completely neutralizing its ability to clot while it's inside the machine. But, and here's the genius part, before that exact same blood returns to the patient's vein, you infuse a separate drip of calcium back into the tube.
Yeah, wow. So the blood inside the machine is perfectly anticoagulated and flowing freely, but the moment it enters the patient's actual body, it's totally normal. The patient isn't anticoagulated at all.
It's an elegant solution. It saves patients who desperately need dialysis, but who would bleed out if given systemic blood thinners. Now, to close out this crisis, there are 2 final mandatory protocols a team has to follow. First, regarding that MRSA infection. Anytime a blood culture shows Staphylococcus aureus, it requires a mandatory echocardiogram, an ultrasound of the heart in every single case.
Because Staph aureus bacteria are notoriously sticky, right? They love to latch onto heart valves. I think it's something like 10 to 20% of these bloodstream infections end up causing infective endocarditis. If you just give antibiotics and don't physically look at the heart, you might miss a lethal valve infection simmering in the background.
Absolutely, you have to look. And second, the radiation oncology team eventually comes by to evaluate the brain metastases. Naturally, someone suggests whole brain radiation therapy to shrink the tumors. But the team has to recognize that the medical evidence, specifically trials like CRRT, strongly proves that whole brain radiation offers no survival benefit for these types of established metastases, and it actually causes measurable, permanent cognitive harm.
It damages their memory, their processing speed, their overall quality of life.
Yes. It is strictly a palliative treatment designed to reduce symptoms much later on. It is not an ICU emergency, and pursuing it now would only distract the critical care team from stabilizing the immediate life-threatening fires.
So what does this all mean? When we take a step back from the massive influx of data we just covered, the ultimate takeaway is profound. You cannot treat a complex system, whether it's a human body, a global supply chain, or a corporate structure, as a collection of isolated numbers on a spreadsheet.
You really can't.
The oral blood thinner interacts with the azole antifungal. The missing calcium is actually a warning about the high phosphorus. The fluid required to fix the bleeding interacts with the physical pressure inside the brain. The true master of any field is the one who sees the intersections. the one who looks at a single elevated fibrinogen number and realizes it changes the entire landscape.
If we connect this to the bigger picture of where healthcare and really all complex data analysis is heading, this raises a deeply provocative question. We're rapidly entering an era where artificial intelligence diagnostic tools will be reading patient charts and analyzing system failures. The hope is that an AI will be the perfect safeguard against human tunnel vision. We want to believe it will instantly cross-reference all 5 fires, flag the liver enzyme drug interactions, and spot the genetic deficiency risks in a millisecond.
That's the dream.
But we have to ask ourselves, if we train these powerful AI models on the historical clinical notes of the very human specialists who compartmentalize these issues, will our algorithms simply inherit the exact same deadly tunnel vision we just spent this deep dive unpacking? We might not be building a flawless systemic thinker. We might just be building a much faster version of the 4 blindfolded men feeling the elephant.
Wow, yeah. Next time you are presented with a neat, clean set of problems in your own work, remember that the real world is never a textbook. Sometimes the most important piece of information isn't the loud alarm flashing in red. It's the quiet number hiding in plain sight, just waiting for someone to connect the dots. Thanks for joining us on this deep dive. We'll see you next time.